is some kind of surgical procedure, right? So they usually don't say patient with MS, they have full weight bearing. Patient with spinal cord injury, full weight bearing. It's always an orthopedic patient. Whenever you see a weight bearing status, and maybe there's one exception to the rule in a million, but generally what will happen if there is a weight bearing status, it's because the patient has an orthopedic injury or a surgical technique, procedure, or they have pain or something orthopedic, okay? So full weight bearing could be that they're gonna be a little limited to pain. They may even not wanna put their foot down because it hurts so much. But you can tell them you can put your weight on it. Okay, now, that doesn't necessarily mean that they don't need a device. It doesn't necessarily mean that they only need a cane, okay? Someone who is full weight bearing after surgery because they get tired easily, or because they're older, or because they just had surgery yesterday, may need a walker just to give them a lot of stability, okay? So you're getting the idea of picking a device involves many, many things, right? Okay. And I think that your book does a nice job on giving you kind of this list of things to consider when you think about assisted devices. So with a walker, you can basically do almost everything except swing through. So you can do full weight bearing. What's weight bearing is tolerated? Whatever they can do. Partial weight bearing is?
Depends. Like the pound, sometimes percent pound.
Depends on the surgeon.
Yeah.
Generally, I'm seeing 20, 30%, sometimes 50%. 50% is probably a little bit too much, and this is your body weight, 20% of your body weight. So I like to do 4-foot type of thing. Usually you're pretty safe, like I said, unless you have a 4-foot surgery, then you do heel, and it usually works okay. Toe touch weight bearing, what's toe touch weight bearing?
Resting only.
It's really not a weight bearing, like if they ask you, is it a weight bearing gait? It's really not. It's just you're putting your toe down
Rest.
to help you to balance. And then non-weight bearing is no weight at all, okay? Now, when you talk about gait, you talk about sequencing and putting devices down. And sometimes some people talk about it in terms of points. Now, I've read like tons and tons of references, and everybody describes it a little bit different. I tend to use, for the gait pattern for orthopedic patients, I always use the weight bearing status because I think it's more important. If I'm treating your patient today, I want to know what the weight bearing status is. I don't care if it's 2 point, 4 point, whatever. I want to know the weight bearing. And so I tend to use points with non-orthopedic patients, and then use weight bearing status with weight bearing with orthopedic patients. You also want to give the side. Okay, so you want to say full weight bearing on the right or non-weight bearing on the left or whatever it might be. Okay? So point gaits, when you talk about points, and again, this differs a little bit in some references, but it's usually how many points are on the ground. And you can progress patients. Like a 2-point gait is device and the leg at the same time, okay? There are some people that call that I don't want to confuse you, but some people call this a 3-point gait. I think it's a 2-point gait. But then, you watch some of the videos and they do it the way I do. So let's do it the way I want it because I think it's less confusing. So full weight bearing, the rule is with, and everybody kind of agrees, you put the device first Sometimes you put the device and the leg together, but it's the device, it's the weak leg goes first, okay? Then you kind of push on the device to give you some stability and on weight, and then you step through with the left. Some people do a step 2 gait. I don't like a step 2 only because it's not normal. And when you progress patients out of an assistive device, you want them to have a normal gait pattern. So I like to do step through. Okay? So, points, you can have a 3-point gait, you can have a 2-point gait, you can have a 4-point gait. And we'll go through each device and sort of the gait pattern with each. So a walker, let's use for frame of reference that my right lower extremity is affected. Okay, so you're gonna be standing on my right side, okay? The way that sort of works well is if you put the device, the walker, to the tips of the toes, you step halfway in with the involved leg, push on the walker, and step through. Tips of your toes, halfway in, push down, step through. You don't want to step through too far because it's going to throw your balance off. You don't want to step here because it's going to, again, throw your balance off. So, walker to the tips of the toes, right foot halfway, step through.
Yeah. So why the weakness go first?
The weak foot is basically supported by the device, okay? So what happens is you can put the device first, push down on the device, and basically I don't even have to put much weight at all on my foot because I'm putting all my weight on my arms. And when you're putting your leg forward, all my weight is on my unaffected side. Okay? So when I'm lifting up, okay, where's my weight? On my left foot, okay, which is my stronger leg. Okay, then I put the weak leg down, I'm pushing down on the walker, and then I'm moving my strong leg forward. Okay, so that weaker or affected leg is really supported at all times. Otherwise, sometimes, you know, if you think of it the other way, if I put my strong leg through, what would I probably do with my weak leg? I'd probably like drag it, right? And that's not a normal gait pattern, okay? So walker, I always like to think that the walker and the weak leg stick together, or the device and the weak leg stick together, the AD and the weak leg stick together. Even on the stairs, it's the same thing. The device and the weak leg stick together, okay? Device, weak leg halfway through, and step. Okay, so that's a full weight bearing. Weight bearing is tolerated, looks the same way. Walker forward, put as much weight as you want, push down, step through. Okay, partial weight bearing, walker forward, little bit of weight, only on the forefoot, push down, step through. Walker, little bit of weight, step through. Okay? Toe touch, walker, only my toe. All the weight goes on my hands, basically.
But
Okay.
if patient is weak,
Toe touch on the right.
but if have weak upper extremities,
Say that again.
if the patient has weak upper extremities,
Weak upper extremities, then probably they're gonna have to probably use the rolling walker if they can't pick up the walker, right? They'll probably just roll it forward. Now, if they have really weak extremities, you may have to get the forearm attachment so they can weight bear on those attachments, right? If they have flaccid upper extremities and toe touch weight bearing, you're really in trouble. Then you probably have to use the one arm drive, right? If they have at least one good arm. If you have, you know, if you don't have a good upper extremity, it's really hard to use the walker, especially if you have a weight bearing status. But luckily, I mean, hopefully, you never know. If it's a motor vehicle accident and they have multi-injuries, you may have to keep them in the wheelchair until they at least have a little strength to get up. But, you know, there are those firm attachments, there are one-arm drives, there are rolling walkers, you know, there are some options to getting them out of moving. What were you thinking about? What kind of pathology?
No, it's just because you're pushing, like using yours. So I was
Right.
thinking like what if?
Right, usually if, you know, with toe touch weight bearing, I mean, it's generally, you know, a lower extremity orthopedic surgery, right? Hopefully I have good upper extremities. If I don't, then it's plan B or plan C. Okay? Okay, walker forward, non-weight bearing, up to you and up to the patient. Do they feel comfortable doing this? Or do they feel comfortable doing that? They have a long leg cast, it's, you know, sort of no-brainer. You gotta keep it out in front, right?
You get more tired that way.
And you get more tired, yeah. So it's walker, push down, halfway hop. Walker, push down, halfway hop.
It's really hard.
It is hard. It is hard.
Is
It's
that
even
the same
harder
with-
with crutches.
Yeah.
It's even harder with crutches. So if they have a lot of trouble with crutches, at least this is a little bit easier. And even a little bit easier than that is the rolling walker, as long as the rolling walker is only a front wheel, not all four wheels. Okay? Now, swing to, drag to, swing through are typically when both lower extremities are affected and they're both paretic or plegic. Okay? So a swing to is this. Okay? A swing to you wouldn't do with a walker because you would wind up out like this. Okay? And you have to have really good upper body. You have to have, you know, at least some of your core and your trunk. It's a fast gait. It's, you know, you get to wherever you want really fast. So it's, you know, someone that's young, someone that's strong, they can do swing through, but you can't do a swing through with a walker because you're gonna lose your balance. So it is either has to be swing to or drag to. Okay? Generally, they'll have bilateral lower extremity braces. Okay? 3-point, like I said, some people, I mean, not so much with the walker, but the literature I've read, they'll do like a 3-point with crutches, like the crutches and the weak leg together. But with a walker, it's generally the 3-point is walker, weak leg, strong leg. 1, 2, 3. 1, 2, 3. Okay? 3-point is more stable because you're just moving one thing at a time. Okay? Walker, 1, 2. 2-point is more of a progressive gait. So it's walker in the weak leg, step through. Walker in the weak leg, step through. Faster gait pattern, but less stable. Okay?
Would you more likely have a rolling walker than that?
Yeah, rolling walker is kind of, you know, you just kind of go with it, and it's more like a 2-point, yeah. But this is 1, 2, 1, 2, 1, 2. Okay?
Some people consider that a 3-point, you said?
No, usually with the crutches in the book, I don't wanna confuse you there. And I don't really, not all the references are like that, but the crutches, they call this a 3-point.
Because they're 2 crutches?
Yeah, 2 crutches in the foot.
Oh, okay.
And that looks like
But-
2-point.
It looks like a 2-point to
Yeah.
me.
Right.
You know, but
Yeah.
the book, I don't know, the book says that. But then when you go on YouTube videos, it's different. Some of the references, I don't know. Then they have these like modified 3-points. It's not necessary to go crazy about these things. Just keep it simple. Okay, 4-point and a 2-point, you can also do with a reciprocal walker. Okay, so a 4-point with a reciprocal walker would be, because you're gonna lead again with your weak leg, okay? And say my weak leg is my right leg or my dominant leg. Now, it's not a weight-bearing gait, right? It's a medical type of situation. So say my right leg is my weaker leg, okay? Or in the case where both of my legs are the same, which maybe, maybe I have MS or maybe I have ataxia, then I'd like to stand on the non-dominant side, okay? Most of us, our strong side is our dominant side. What do you think? True? True for you guys? Okay. So when I see bilateral, everything's sort of the same bilaterally, I'll ask them, what's your dominant side? With the kids, what do you ask? What hand do you write with? Exactly. What hand do you write with? Because they don't understand dominant, non-dominant. And then I'll stand on the non-dominant side. I'll stand on the hand that they don't write with, okay? So a 4-point gait, depending, I'm gonna say my right leg is the weaker leg, so I'm gonna do, of course, a reciprocal gait pattern, right? So it's walker, right, walker, left. And you gotta kind of talk it out loud to get the sequencing down, but it's left arm, right leg, right arm, left leg, left arm, right leg, right arm, left leg. Say it with me. Left arm, right leg, right arm, left leg, left arm, right leg, right arm, left leg, left arm, right leg, right arm, left leg. Okay. So that's your reciprocal. And sometimes, if you get your rights and lefts mixed up, you can just do this. Do a little tactile cueing there, right? Tactile cueing, I love it. Okay, then you can progress to a 2-point gait. Left arm and right leg, right arm and left leg, left arm and right leg, right arm and left leg, left arm and right leg, right arm and left leg. Okay? That's a 2-point with a reciprocal walker. Okay? Good? Okay. Do you want to practice this a little bit before we move on to the next device, or you want me to go through all of them and practice at the end? Go through everything or practice? Go through everything? Okay, can somebody advance the slide for me? Because you're comfortable sitting. I feel tired. How about you guys are just- Okay, so axillary crutches, and we have to switch these because these are not a pair. You're gonna get really mixed up when you adjust them. Just tell Mr. Mitchell to get the other ones out. Okay, so for axillary crutches, just put these up a little bit for me. That's as high as they go. Like this one's the pediatric walk, the pediatric crutch. I think. Is it? Yeah. Tallest is 5'2". Okay, full weight bearing. Okay. Crutches, weak leg, step through. Crutches, weak leg, step through. Crutches, weak leg, step through. Full weight bearing. Okay? Weight bearing is tolerated. Crutches, weak leg, step through. Crutches, weak leg, step through. Crutches, weak leg, step through.
Is that a 2-point?
That is, I'm doing weight bearing. Okay, so, like I said, usually I'll say patient ambulates with axillary crutches, full weight bearing on the right, about 20 feet with contact guarding. Okay? And when we, next week, when we get through the exams, we're gonna start, doing more Gait. I'm gonna have you really kind of parrot that phrase, because I think it helps when you organize your words, you organize your head. Okay? So it's patient ambulates with, what's the gait pattern,
Full weight bearing on the right, 20 feet.
right?
Contact guard.
Then, how many feet, with what kind of guarding? Okay, and that's your sentence. So for instance, patient ambulates with axillary crutches, and you always wanna put axillary because there are loft strands and Canadian crutches. So patient ambulates with axillary crutches, toe touch weight bearing on the right, about 30 feet, requiring contact guard. Okay? Patient ambulates with a rolling walker, demonstrating a 3-point gait pattern, about 50 feet, requiring minimal assist. Okay? Those are some examples. Okay, so axillary crutches, little bit of weight on the right side, step through, crutches, little bit of weight, step through, and you see that I don't have my 20, 30 degrees, which I really should. Crutches, little bit of weight, step through, crutches, little bit of weight, step through. And when you walk with the crutches, you just keep them pinched next to your chest, okay? Toe touch, crutches, only your toe, step through. Obviously, you have to have very good balance for this, okay? This is not for the faint at heart. Because really, you don't want to put much weight at all, okay? So it's a very short step length. Okay, crutches, front or back, whatever's easier. Crutches, little hop. Crutches, little hop. Crutches, little hop. That's a non-weight bearing. Okay. Drag 2. Swing 2. Swing through. Okay, just be careful when you do that one. Okay, the main thing is to keep your crutches pinched. Okay? Some of the books actually even called non-weight bearing a 3-point gait. I don't get it, but crutches, non-weight bearing. I just think non-weight bearing is better because it's confusing, and that's the most important thing, was the weight bearing status. Okay, 4-point. Left crutch, right foot, right crutch, left foot, left crutch, right foot, right crutch, left foot, left crutch, right foot, right crutch, left foot. 4-point. 3-point. Crutches, weak leg, strong leg. Crutches, weak leg, strong leg. Okay? 2-point. Left crutch and right foot, right crutch and left foot, left crutch and right foot, right crutch and left foot, left crutch and right foot. Okay? Good? We got them all right.
Can you do one more time the 3-point?
3-point. Crutches, weak leg, strong leg. Crutches, weak leg, strong leg. 4-point. Left crutch, right foot, right crutch, left foot, left crutch, right foot. Progress to a 2-point. Left crutch and right foot, right crutch and left foot, left crutch and right foot, right crutch and left foot. Okay. Good? You get the hang of it. Okay, loft strands. They can be used for weight bearing, but it's hard. And usually when I think of loft strands, I think of, I think of neuro patients. I don't really think of, orthopedic patients. Make sure you practice these because okay, so same gait patterns with axillary crutches you can do with loft strands. Like I said, generally you don't see them with non-weight bearing, and you don't see them much with weight bearing statuses, but you can do it. So full weight bearing, crutches, weak leg, strong leg, crutches, weak leg, strong leg, okay? Weight bearing is tolerated, crutches, weak leg, strong leg, crutches, weak leg, strong leg. Partial weight bearing, excuse me, thank you. Crutches, little bit of weight, step through. Crutches, little bit of weight, step through. Crutches, little bit of weight, step through. Okay? Toe touch, very hard to do with loft strands. Crutches. Okay, non-weight bearing, really clumsy. Right? Usually not happening. Not wrong, not awful, but probably you won't see it. Okay? You usually see more of the drag twos, because it's like post-polio patients, patients with MS, those kind of things. Swing two, and then the swing through. Okay? They're a little less hard on your shoulders, not that much, but a little bit easier on your shoulders than the axillary. So these tend to be, like long-term neuro devices. Patients with cerebral palsy, patients with post-polio syndrome, patients with MS, patients with lower extremity paralysis or paresis, that kind of thing. Okay? Okay, let's switch the slide, please. They might. Although hopefully you would get them to the point where they didn't have to use anything. When I worked in Buffalo, I was in PT school, I was a PTA, and we had a prosthetist at the hospital who probably for almost 8 months, I didn't even know that he was a double amputee. Because he was up, he was kneeling, he was transtibial, bilateral transtibial. Like when somebody told me, because I just never picked it up, I had no idea. And he would be in the parallel bars, and he would be down on his knees, and then he would be popping up, and then he would be down again. Then he would, he was just so active and so mobile. So some patients really, really do well. So would you see that? You could, right? Hopefully, eventually, maybe they wouldn't have to use anything. I've seen many, many patients with double amputations that don't need any device at all eventually. In the beginning, obviously, right? But then, not so much. Okay, so any of your unilateral devices, they go on the strong side, okay? So with unilateral devices, the cane goes on the strong side. With your quad canes, you want the flat side next to your body. and you want the part that fans out is away from your body. So this is for my right side, and you guys, I told you how to change it, right? You just do a 180-degree turn for the other side, okay? So this is a right for my right side. Now, hemi cane, large base, quad cane, small base, quad cane, some people call them wide base, narrow base, standard cane. Don't forget, you can only do full weight bearing when weight bearing is tolerated, right? You can't do any of the other weight bearing statuses, okay? Can't do a swing to, a swing through, a drag to. So you're basically kind of stuck with the weight bearing is tolerated, the full weight bearing, the 3-point, the 2-point, okay? And again, mostly neuro or medical patients. The wider the base of support, the more stability, okay? So that hemi walker gives you pretty much the most base of support for your unilateral devices. A straight cane gives you basically not much at all, okay? Doesn't help much, but keeps you from tipping over when you're outside. Okay, again, the cane and the weak leg stick together. So it's cane, weak leg, step through with the strong leg. Cane, weak leg, step through. So the cane and the weak leg kind of form this stability pattern. And it does help to support that weak leg. So advance the cane, weak leg, strong leg. This is a 3-point or a full weight bearing or a weight bearing is tolerated. Okay, cane, weak leg, strong leg. Cane, weak leg, strong leg. I can progress to a 2-point gait. Cane in the weak leg, step through. Cane in the weak leg, step through. Cane in the weak leg, step through. Now, patients may feel more comfortable doing a step 2 gait, and that's okay, this kind of thing. That's called a step 2. It's okay in the beginning because they don't feel as comfortable, but eventually you really want them to get that step through because that's really much more of a normal walking pattern. Okay? You can do a 4-point if you have 2 canes. Say you had 2 straight canes. Some people like, 2 straight canes. They don't need as much stability, but they want it. So it's, cane, weak leg, cane, other leg. This could be like a 4-point. But you would need 2 canes to do a 4-point. Questions? Good? Okay. All right. So can you give me the guarding? Can you do the guarding? I don't know if it's next or not, but it says guarding on it.
So the point system is for what is it, neuro patients or?
Non-orthopedic.
Okay.
Could be neuro, could be medical. I call it medical.
What is
Could be a cardiac patient, could be a pulmonary patient that just needs it for some energy conservation, but they don't have any weight bearing status. Okay? Do you mind to walk with this? I'll guard you. Okay, now, when you guard, you go into ready stance, and your book does a nice job of talking about how to guard someone and what not to do. Like to do this, they have this circle and says no, because what happens if they fall?
Boom.
On his
Dislocation.
arm out of his side, exactly. So you want to make sure that you have that patient as secure as possible, thank you, and that if wherever they go, you have them, okay, you have them secure. So I wanna put my hand, cup it around his shoulder, and I'm gonna put my other hand around, I like to hold on to the ASIS if I can get it, okay? Now, if the patient has a belt, even better, you can kind of hold on to the belt, which he does, which is nice. But if they don't, and inpatient, patients that are inpatient in rehab in the hospital, they have nothing. They don't even sometimes have underwear on. And so even if they have underwear, don't hold on to their underwear. Because it's gonna be very uncomfortable, okay? When in doubt, use a gait belt, right? And you don't wanna hold the gait belt like this, you wanna hold it like this. Anybody know why? Because if they go down, what are you gonna do? Pull them towards you, okay? And you have much more strength in your biceps, okay? Instead of like this, okay? Now, you are you're on the side, your feet are wide apart, and you're a little bit behind, okay? I don't wanna be in front, because if he goes backwards, I can't catch him. I don't wanna be totally behind, because if he goes frontwards, I can't catch him. So I wanna be sort of at a diagonal, okay? And I'm gonna instruct him, cane forward. Make sure your cane's flat on the ground, make sure it's flat on the ground. Step halfway with the left and follow through with the right. Okay, cane, good. And I'm watching his face. I'm asking, how are you doing? Okay? He's doing a 2-point now. 2-point step 2. That's okay. Just want to get the idea. Okay? So you're always there just in case. And we're gonna, I don't know if it's next week or the week after, we're gonna do controlled falling. Okay? So weak side, shoulder around the waist, a little bit behind, your feet wide apart. Concentrate on your patient. Don't be talking to your colleague what you're gonna have where you guys are going for lunch. Okay, you've gotta be with them. I can't tell you how important it is and how quickly some patients go on you. Okay, it happens really, really fast. Okay? All right, so that's sort of everything that we're gonna be doing today. Guarding, walking, devices, sit to stand. And it's probably too late to take your break now, right? It's going until 12:30. You wanna go take a break now until 10 after, and then 10 after 11, and then you'll have sort of an hour and 20 minutes to practice all this. Does that sound okay? Okay, all right, go ahead. And then